Hello, everyone. How about everybody here for a full session on the lunch hour? That is so impressive. Thank you, everyone, for being here. I think they're going to shut our doors for us. Full house. My name is Phyllis Ferrell, and I'm here today with Eli Lilly and Company, and we're proud to sponsor this symposium. I'm sure that you all are going to be very excited to hear from our speakers today. One piece of housekeeping. Some of you may have already received a survey. We'd love to get your feedback. We have a team that works very diligently on putting these sessions together, and they're only good if they're valuable for you. So if you'll let us know what you thought. If you did not get one of these, there is a QR code that will come up during the presentation that you'll be able to click on. Okay, so what we're going to talk about today is optimizing Alzheimer's disease healthcare, and specifically looking at the pathways. What we know is that we have had a huge amount of progress in the scientific field, but we know that those innovations and that progress has not made it to the patient yet. And so we're going to talk about why things are difficult, but more importantly, we're going to show solutions as to how we can actually move innovation from academic research into clinical practice as quick as possible. Some of you may not know this, but the literature shows across any disease state, it takes 17 to 20 years for an innovation to make it out of a research setting and into standard clinical practice. Now, if any of you have had experience in this disease like I have in your families, we don't want to wait 17 to 20 years for a progressive neuropathological disease to come take our families. So we're going to talk today about how we can actually improve that timing and improve the care pathway. I think I'm clicking. There we go. Okay. So we have a wonderful panel with us today. They're going to make my job very easy. First, we're going to hear from Marguerite Keating. She's going to actually tell us her own lived experience in the diagnostic journey. Now, we all know that really every patient's experience is an experience of one, and they're all a little bit different. But it was really critical for us today to start with Marguerite's viewpoint. She's also a dynamite speaker, and I know that you'll enjoy hearing from her. Next, we're going to move to Dr. Jane Mahakian. Jane is going to talk to us about her experience in Alzheimer's Care Armenia and doing outreach and community engagement around early detection. Then Dr. Ira Haraldsen is going to talk with us about how to actually use technology to do a better job in this diagnostic process, and how technology can be used to make things both more effective and more efficient when we think about our strapped health systems. And then last but certainly not least, because I'll probably have to grab him with a hook at the end of his time, is Dr. Craig Ritchie, who's here from Scotland. He's going to talk about the real-world practice of care in Scotland, and you're going to hear from him specifically about the brain health approach. My intention is that we will still have lots of time for Q&A at the end of the panel. So keep your thinking caps on as you hear from these individuals, and I'd love to be able to take your questions. So let's start with a framework. The Davos Alzheimer's Collaborative is the third largest global health initiative created by the World Economic Forum. It was created behind Gavi and CEPI, which some of you may have heard about if you've heard about COVAX. Those are two large global health initiatives focused on communicable disease and immunization. However, when you look at Alzheimer's disease has potentially an even greater impact in our world than COVID. It's hard to believe because COVID was so acute. But when we think about a global aging population where we've done quite a good job on mortality and morbidity, and you've got lower birth rates, later marriage rates, you have situations like Japan, super aging society, China, a one-child policy, and this is marching its way across Europe and into the United States, where our social systems have been turned upside down. For that reason, the World Economic Forum has partnered with a lot of multilateral organizations to create this large global health initiative called the Davos Alzheimer's Collaborative, or DAC. The very first thing this organization did was said, what problem are we trying to solve? And so what you'll see in front of you is basically a framework that was created by a large multi-sector, multi-country group in 2020 to define what does good look like when it comes to health system preparedness for an aging population. And our panel today is organized around these groups. So on the left, you're going to see awareness and activation. How do you make sure that everyone in the community, all of the providers, all of the hospital systems, and all of your potential patients or people who have an interest in brain health are aware and activated about what it means to take care of your brain? The second step walks into the health system. At this point now, you're talking about how do I do early detection of cognitive symptoms? We know it's always better to catch diseases early. I don't think anyone wants to be told their cancer is stage 4 instead of stage 1. The earlier you capture any disease, the more degrees of freedom you give the family and the patient who's going to have to make those choices. It's the same with Alzheimer's disease. So the first step is how do we detect those symptoms as early as possible? Then the second step is how do we make sure it's an accurate diagnosis? So how do we make sure that it's not geriatric depression, which by the way can look a lot like Alzheimer's disease, or that there's not a urinary incontinence med that's causing cognitive impairment, or a B12 deficiency, or some other form of dementia that we may not actually have the right medicines being prescribed. So that's the second step. Then you get to the third step, which is around health management and delivery. That's what's in the health system, services and social support, all surrounded a patient-centered care plan and dementia care. So that's the model, what you're going to hear today. So Marguerite's going to start us off with her personal journey. Jane's going to talk about kind of awareness and activation. Ira's going to talk about how do we actually screen and detect as simply as possible. And then Craig's going to talk about what happens when you're actually in the care plan. So that's our flow for today. This slide can be made available. If not, there is a citation that's provided at the end from Dan Ball as the lead author, and you can pick up the history here there as well. Okay, for those of you that are standing, there are plenty of seats right here, and I promise we won't cold call if you'd like a front row seat, and there's some on this left side as well. Okay, we're gonna speak from this side. Marguerite was a dancing fool last night, so she is going to do her presentation from this other side of the room. Oh, I should have known, Marguerite, that you'd get all sorts of hellos as people walked by. Okay, so can I have this mic activated for Marguerite, please? So you should have an active mic here. Yep, you're live. There you go.
Hi. So they asked me questions. Is that okay? So they asked me questions and I answered them. So I'm going to tell you the question and then I'm just going to ad-lib. Tell us about your diagnostic journey. What worked well and what didn't work well. So I'm an artist and I taught art for 22 years to a company, a charity called Brothers of Charity, and for people with learning disabilities. And it was great fun. So every morning I went in and we'd have a few songs and then we'd paint and, and we'd sing a lot, but just a lot of fun, and they had computers and, there's a lot of work to be done, on your computers and all that, and everything has to be documented and all the rest of it. And I started to kind of get confused at the computer, and I started to get some of the appointments mixed up. So we were going for a hairdressing appointment, but I'd bring them to the chiropodist. And I just laugh, I say, oh, sorry about that. And think nothing. And a couple of years later, my boss said to me, well, I just thought you were a bit of an artist, you're a bit zany, you know. So I kind of got away with it. And I suppose it would be in my personality. I actually come from an alcoholic home. My father's an alcoholic, and he had no problem me saying that because he's 44 years sober. And but he was, he'd always say to you, you know, fake it to make it, you know, keep going, you know, no matter what. And I suppose I'm very like him, even when I don't want to be, you know, I'm very like his personality. And it was always, you know, just as they say in Ireland, keep going, you know, and that would be my thing. So no matter what was happening, I would minimise it. That's just the way I am, you know. But so I just kind of brush it off and kind of keep going. But it was kind of coming a little bit more prevalent at work, you know. I'd say it must have been real pain to work with because I was really making a lot of mistakes. But one morning, they had nobody to help. And so I was in this, like a classroom setting. It was as big as this room. And I had 8 people on my own, all with special needs. And some of them didn't work. I have 2 wheelchair users. And 3 of them were Down syndrome, so all adults. But I'm very used to them. They're used to me. And so it was on my own, and I didn't realise anything was wrong or anything until afterwards when I was told, we call them the lads, you know, as kind of an endearment. And he said, Marguerite, you gave the lads their lunch and their tablets at 11 o'clock. Was in my head was, don't forget anything, you know, so because I was kind of a little bit under pressure with remembering. So I gave them everything at 11 o'clock, their food and their tablets. No, it's not supposed to be till 2 o'clock. But anyway, I said, well, they got them, you know. But yeah, so, well, they can't have that, you know, in the company, I get that. So they said, would you go and see somebody? So I said, okay, you know, that's fine. Now, I did get trapped in an elevator with 2 of the lads for 2.5 hours. And I kind of thought, and I was singing to them and trying to make them, you know, not be worried and that. And I kind of thought, you know, that only happened. I kind of thought, I'd say it's a little bit of trauma from that, really, you know. It's not. So, yeah. But anyway, see, making excuses for myself. So anyway, went to the doctor. The doctor sent me for tests up at the memory clinic. And they told me, before any results or anything, they told me, yeah, it's looking like you might have some kind of dementia. So I want you to give up work, stop driving, and get your affairs in order. Now, I was 55. That to me is just rude, you know, really. But yeah, and eventually, 9 months later, I had a lumbar puncture, I had brain scans, I had blood tests and all the rest of it, and they came back with that I had Alzheimer's, early onset Alzheimer's, and that I had a considerable amount of plaque on my brain. Sure, I'd never heard of anything like that, you know, before. But anyway, that day that I was diagnosed, it was the 14th of February 2018. 14th February was Valentine's Day. I got no flowers. And I was told that, you know. And my cousin that was with me, she had to leave because she had a small child to bring to nursery. So that evening I was on my own, totally on my own, and I was so devastated. I didn't know what to do, you know. I thought, you know, this is the end now. I had a 14-year-old. Like, how do you organise Alzheimer's and all your death around a 14-year-old? How do you say to your 2 daughters, one was expecting her 6th baby, you know, So anyway, that day, I actually thought I would be better. It would be better for them if I took the elevator, you know, because then they didn't have to watch me. Then if it's going to be the same end, what's the point, like? No one told me there was any help. No one told me, actually what they said was there's no cure, but we'll pop into you from time to time, which actually never happened. So it was really, 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 it was the lowest. I've had some shit hit the fan in my life, I tell you, but this was like top level. I just didn't know what to do with it. I've got through some crazy things. My husband said to me one Monday, and gone to my mother's, and I said, "Oh, lovely for your dinner," and he says, "No, I'm not coming back." "Oh, well, thanks, yeah." And I like, what? And I got through that. I didn't go to the river. I didn't, I picked up my 2 children and carried on, I was absolutely like, I was like, what did I do wrong? But this was just so devastating. Any diagnosis for anyone is devastating. But this is like, all I knew about Alzheimer's or any dementia is you lose your marbles. And I was saying enough, like I didn't really need any extra bits going. But it takes your soul, it takes part of you, it makes you feel so nude, naked and vulnerable. Like, what am I going to do? I'm this little fairy kind of person that I like to do things to other people. I like happy. I've never been depressed a day in my life. I'm hyper as that, But, and this was just slap in my face, and I didn't know what to do with it. And my beautiful girls, how do you say that to them, My daughters, the 2 older girls, my baby now is 19, right? So she was 14 and the other 2 were in their 30s. One lives right at the other end of the country up near Northern Ireland, Donegal, which is 6 hours from me. And the other one, 6 children. So she wanted me to move in with her. Yeah, you think so? The other one wanted me to move to somewhere that I know nobody. And they all talk like this, Hello, how are you? I don't have a clue what they're saying. And they wouldn't have a clue what I'm saying. And then my 14-year-old, she wanted to go to her dad's. I'm out of here, So, yeah, I decided, now hold on now. I need to take back my own. So the little red-headed bull in me started to fight back. And straight away I started Googling numbers and the Alzheimer's Society, the ASI of Ireland. And they were on my doorstep the following day. I went to the Clonmel is about 25 minutes from me. It's a big town. It's kind of like our city in Tipperary. I went to the Dementia Technical Library. They were so good to me in there. They did courses and helped me with strategies of trying to organise things, and so that I wasn't in a tizzy, so that I knew how to organise things. I got a clock that just had the number, because when I look at the clock with the numbers on there, the numbers jump on me. And it's hard to explain. It's just too much. So money, how to organise, a whole load of things that I wouldn't have known about. And more than anything, I met people in the same boat as me. And I started to fight back. Now that has been my thing. I was really peed off with how I was treated in the beginning. It's nobody's fault, really. It's ignorance. We don't know any better. And you know what? My doctor, she wasn't nasty, she wasn't mean. She was frightened. She knows me for years, and she knows me to bring in my lads and say to her, I actually think that foot's broken, or I think that, you know. And she said, you are my go-to person. And then all of a sudden, you know, I'm on the other end. That's frightening for a doctor, for anyone, for my family. It's scary. So I was thinking not about me. I don't know, will I ever get a cure or will I ever get anything? But what I do know is it has to be better for the Marguerites coming behind me. And that's what I work very hard for. Maybe my grandchildren, you know, I don't know. But that's what I really strive for. And I don't do negativity. You probably guessed that. I don't do negativity. I do as much as positive as I possibly can. And the second question was, finish this.
I think you answered it already. I think you answered it. Marguerite,
Well, the second question was what doesn't work.
I think you answered it, yeah.
And what doesn't work is negativity.
Yeah.
That's it.
Marguerite, you're amazing, and I know the group's going to want to hear more from you. Let's bring up Dr. Mahakian. You know, one of the things that I think, Marguerite, when I met her yesterday, my first thought was, thank God she didn't take the elevator. Can you imagine the joy that this world would have missed out on for someone who says, I'm allergic to negativity, dancing last night and still here today? And I just can't imagine what the world would have lost out on. But I think the other thing I took away from our conversation, and you mentioned it again, is by having an early diagnosis, you got to have your voice in your care plan. It wasn't taken over from you. It was your voice as to kind of what you wanted. And I think that's where the human right and dignity of an early and accurate diagnosis come along. So Jane, come on up here and tell us about what you're doing in Armenia. Here is your clicker. And your slides right there.
And how does it work? It's the green one. Ah, okay. Hello, everybody. Good morning. Oh, no, actually, good afternoon. Okay. Good afternoon. I'm Dr. Jane Mahakian. I'm a gerontologist, and over this last year, we had an amazing project in Armenia, the Brain Health Armenia project, which is an early detection, memory screening, and training program, countrywide, mobile, in Armenia. So basically, what we really were looking at here is some of the issues in Armenia prior to starting this project. And so one of the problem statements, shall we say, in Armenia is the public, the community is really not focused on brain health. There's quite a lot of stigma and misbeliefs in the country, and there was really no system, organized system, electronic system in the country for tracking, for standardizing care of that person that has a cognitive impairment. And also a very big important point was the gatekeepers, those primary care physicians. They lack information, they lack training on memory screening. So that's a little bit about the background, right? So this is a part of our team. We had a multidisciplinary team. The Brain Health Project was a project funded, of course, by Davos Alzheimer's Collaborative System Preparedness Project. And our team, through rain and shine, we have a DAC mobile now, a car, a van, that took our team around the country, where we conducted over 4,388 screenings throughout the country in a period of 11 and a half months. The project became a pipeline in Armenia for early detection. The team screened people between the ages of 40 and 94 in 39 villages and towns in 6 different provinces throughout Armenia. We utilized the Montreal Cognitive Assessment Test, and we also utilized a basic healthcare screening. What we decided to do, this is a little bit about our team. What we decided to do was we partnered with a mobile eye care project, mobile eye screening, mobile eye hospital in Armenia that had been established for over 25 years. And in that partnership, we wanted to be able to screen those patients coming in, and it actually worked out quite well. So interesting, too, is that 80% of the people screened were women. It made it easier partnering, our team to partner with a mobile eye care clinic, because people were coming in for their eye tests, and then they were coming in, of course, to have their memory checked. So we also built relationships throughout the country with different clinics and hospitals and polyclinics. So we were able to reach that primary care physician and train them in the ins and outs of memory screening, as well as the basics of Alzheimer's disease. I really think that the success of this project really was attributed to our team's dedication and innovative approach to really capacity building in the country. Another key to success was really kind of thinking out of the box, right? How could we reach more primary care physicians and do more screenings in hospitals and clinics, in addition to our screening with the mobile eye hospital, was to create a radio show. And it was probably since 1934 in Armenia. There's a national radio show that's very popular. People listen to it. So we decided to start a show, and it is still called, Second Start. And it's all about brain health. It's about redefining what it means to be an older person in the country. And it is a smashing hit. And it's every week the interview of different professionals, healthcare professionals, people that have a cognitive impairment, people from the United States or Europe who want to be on the show, and are neurologists or psychiatrists. So it's been quite popular. This is, as I said, a little bit about our team. And then basically, this gives you an idea of what was accomplished, right, in the early detection screening. And this can give you an idea, too, of as I had said, the total number of people screened, and the percentage of people that fell in the mild cognitive impairment range were 24.75%. So we have these people. Now what are we going to do, right? So we decided to expand this project, and it started 3.5 weeks ago. In fact, one of our doctors of the program is here, Dr. Sona. And we decided to expand it to provide in-home care, more like a care management training and education of the family carer, as well as making sure that that person doesn't fall through the cracks, connecting him or her up with resources and information, as well as making sure that the family has those resources as well, whether it be counseling or other types of home safety evaluations. So that's what the in-home care project is off now. We've seen perhaps since October 4th, 30 people so far, 32 people. And we're getting more calls every day. This is some photos of our team, as well as some trainings that we did. So the early detection screening can be improved, right, by developing a more coordinated approach for primary care physicians' visits for people over the age of 40. That's something that we're working on. You know, Armenia now has a national dementia plan. And part of that plan is training these physicians. This project was instrumental in moving that plan forward to acceptance by the government. Dementia training and education, as you know, is a very powerful tool. So we're really working on building that workforce capability and workforce capacity by continuing to offer the continuing education of the primary care physician, those gatekeepers. So let me tell you a little story, only for a few minutes, about Hamlet. And Hamlet lives with his daughter in Armenia. We received a call from the daughter saying, can you please, I heard about your project, the Brain Health Armenia project, can you please come to our home and conduct a memory screening on my dad? We don't, you know, we really want you to come to us. And I said, well, sure, we're happy to have the team come. And what's going on? Well, he stays in bed most of the day. He refuses to bathe very infrequently. He's having eyesight problems, and we think it's due to some kind of dementia that he has. He's hearing impaired, and he really kind of is shutting down. He's not very social. The team went out. This man had not been diagnosed with a dementia. The team was able to conduct a screening, a MOCA screening, and the team also referred him to one of the leading neurologists in Armenia. What we noticed was that the daughter had quite a lot of myth and misbeliefs about dementia. And so much so that she believed that her father's eyesight was due to cognitive issues. What we decided to do as part of the resources and information to give to the daughter was Hamlet went to the eye care project and had a thorough eye exam. And it revealed that he had cataracts. So he had severe cataracts that was causing his near blindness. He had the surgery, which was very quickly, within 2 weeks, he had the surgical procedure. And we even have videos of that, picking him up and having him in the snow and driving him to the hospital. All of a sudden, he could see. And we had his ears, his hearing checked and hearing tested. And with hearing aids, he could now hear. He does have a cognitive impairment. He does have dementia. However, his quality of life has improved greatly as a result of improving the hearing and the eyesight. So what have we learned, really? As I had said, one of the biggest issues is post-diagnostic follow-up. Countrywide, in every village, in fact, in more villages than in the urban area of Armenia, there are higher incidences of people having some degree of cognitive problem. So we're focusing on that right now this next year, on looking at how best to support these families and the person. And we're also working very diligently on combining our work with the Ministry of Health in Armenia to develop different activities and initiatives to look at stigma, to look at myths, and to change really the landscape, continue to change the landscape in the country. So I want to thank you very much for the opportunity.
You can see why we're so proud of Jane and her team in Armenia. What they've accomplished is incredibly impressive. Okay, so Dr. Haraldsen's going to come up and speak a bit about how we can use technology. If you remember, now we're moving out of the community and into the health system.
Thank you so much, Phyllis. I'm very happy, Marguerite, to have met you here. And I'm very glad being invited to speak here, because when I hear your story, we could have made it better many years before. And it's the same motivation from my side, like this audience. I will expand my lecture a little bit. Behind in this room is one of my PhD students sitting. And when I saw how slowly his academic work went, then Ira Mind was born, because we do not have the time. It is really ridiculous sometimes to experience that for science and technologies have been developed 20 years ago and they are not implemented in the clinic. So there is hope, because I'm myself as well a non-depressive personality and always working hard to make a little step forward. Today, I want to introduce you to Ira Mind, which is an intelligent digital tool development for screening brain connectivity. That is a technology we know all about already 20 years ago. But again, it never made it to the clinic. And why didn't it make it? It was too complicated. To calculate brain networks, you have to be an expert. But modern supercomputers and automated digitalization make it possible today to introduce such technologies and the theory in everyday clinics. And that is what Ira Mind is about. I have some conflicts of interest. I'm also the shareholder of a company called BrainSynth, which is a partner in Ira Mind, and I'm as well associated to Eli Lilly. And I want that you meet Mary, just like Marguerite. She is a 65-year-old working as an office administrator. She is a typical European patient in our polyclinics. She's experienced memory lapse, some changes over time, and she is personally concerned. But no one in her family is concerned. Everybody is neglecting and do not want to see it. But she has a history in family of dementia, and she is consulting her GP. And what is happening nowadays in Europe? It takes you usually between 5 and 8 years to get a diagnosis, because the GP is maybe also underlining, yes, you are right, you have some mild cognitive impairment symptoms, but I can't offer you anything, and come back to me in a year. That is the standard, and it takes 5 years then, from then on, when you're finally starting mild dementia symptoms, then you are finally diagnosed, but you are not diagnosed early enough. And what Ira Mind is doing, we will classify MCI as a risk, and we will then estimate, are you in the 50% of MCI subjects which are in fact at risk, because 50 other persons are not at risk. And we have to select early enough the right patients to intensify the diagnostics earlier. So as I mentioned, and we have said so, and Phyllis has said, it is a bigger pandemic than COVID. Of course it is, and we will double soon the numbers of demented people. And as I mentioned, 50% are at risk, 50 not. And also the not at risk need to relieve and get a correct diagnosis. We have no screening today existing on a population-based level. We are always too late, and we give our doctors no tool into the hands to predict correctly. We wish in the future that you are going to your doctor, you are examined as usual, the doctor is doing something different in the waiting room, he gives you already a digitalized iPad which is testing you. You should not wait to get an appointment in 1.5 years at a neuropsychologist office. This is not possible. And neuropsychologists are not a monopoly which can hold on information which we as a citizen deserve. I need to know as a human being, am I impaired or not? And that is not very difficult. It's maybe not perfect, maybe a new psychologist is better, but it has to be good enough. That is the point. Then the doctor will take in the future a blood probe with new blood biomarkers, which are as well clinically not available. They have to become available. And all these results we put into our algorithm, and then we are predicting. And I think it is helpful to end with a stigmatization, to introduce MCI as a phenomenon which will affect a lot of us here in the room. And it is not something special. It is something which is pretty common. And that we have to understand, and we will get help. The pharmaceutical industry and the researchers are working hard. And although we do not have today maybe the right answer for each patient, we can become better. So what we started with our clinical study, and that is important, we did not want to repeat research as usual and never make it to the clinic. We started in 22 and we collected in parallel to our algorithm development. We started a clinical study recruiting MCI directly from our populations. And in 2025, we will have then 4,000 blood samples. We will have 4,000 cognitive tests and 4,000 EEGs. And then we will finally test if we predict with our algorithm correctly. A side effect, which was very important, was that we left traditional medical investigation. What we did is we went, like during COVID with your restaurant order, we went to QR codes and we made it accessible for everyone to test yourself, to standardize the procedures between doctors, because that is also a problem, the subjective evaluation of one doctor. Then we transfer automated everything to one secure SSD server so that the GDPR rules of the European Commission are fulfilled. And we make it so standardized, all procedures, that in fact the medical device regulations are possible to be applied, and that the FDA and the European Medical Agency can in fact approve our device. Very important, and we talked yesterday about is the health technology assessment, which we as well standardized for different European countries, because each country has different financing systems of their healthcare system. And to motivate the public healthcare systems or the private ones to introduce AI Mind, it is important to give them tools to evaluate the real quality of life and the cost-benefit calculations. And when this is then the end, then we hope that we are so transparent and sustainable in development of AirMind that we make our server accessible for all your countries, and that you can access the server, you can deliver your data, and we can see if our algorithm is also functioning in the US. And last but not least, Roche became then partner and was very much helping us now to guarantee the sustainability and the introduction of AirMind in the future in our healthcare systems. And not in 20 years, but maybe in 5.
In 5. Or 1. Thank you, Ira. I know we rushed you quite a bit there, but we will definitely have time for a few questions, and I'm sure that you're willing to stay afterwards if people have future questions. But yes, let's do this in a week and not years. I was thinking, as you were talking about the current situation where someone goes into their doctor and the doctor says, oh, let's give it a year and see what happens. There's a lot of women in this room. If you found a lump in your breast and you went to the doctor and the doctor said, let's give it a year and see what happens, what would you do? Find another doctor, right? And so I think we need to take the same sense of urgency here. Craig, bring us home. You're good. You're all
Let's go. Let's do this. Okay. Yeah, because I think we really want to leave some time for panel discussion. So I'll sow some seeds in this presentation about what we're doing, what we have been doing in Scotland really for the last 3 or 4 years as part of the sort of brain health initiative. Giovanni gave a wonderful presentation in plenary yesterday about this, so new memory clinic, the Brain Health Clinic, and we've been enacting that in many ways for the last 4 or 5 years in Scotland. I want to share some of that with you. These are my disclosures, which are meant to leave up for 30 seconds apparently, but we're running out of time, so I won't. But I'm up to my neck in it, is probably the safe way to put it. So what I'm going to cover in the next 3 or 4 minutes is Brain Health Scotland and the Scottish model. I'll talk a little bit about a clinic I've been running since May 22 for ex-international men and women rugby players in Scotland, which follows the brain health model, the Scottish model for brain health clinics. And I'm going to illustrate this with a case study, a real ex-player, former player, who's been involved in the clinic. And I think that's really quite important to share these experiences and his reactions to the service, and then some closing remarks. So I think one of the most important things to highlight from this slide is not just, Anna Borthwick, who's the executive lead, Henry Simmons, who's the CEO of Alzheimer's Scotland's involvement in this, but it's the top right-hand corner. That this programme of innovation, of clinical practice, has been fully supported by Scottish Government. In fact, they fund the initiative. There's some complementary funding we found from other sources. But it was in a meeting in 2018 that I had with the then First Minister Nicola Sturgeon. Henry and I went to meet her and advocated very strongly for actually saying, you know what, the research is good enough. We don't necessarily need to do a whole bunch of more research about, lifestyle interventions, comorbidities, etc., to be able to actually implement some of this work into clinical practice. And our whole sort of motivation is really focusing on health, brain health, and towards a midlife population. And some of you yesterday have been in the presentation from Sophie about the schools programme we do for 10-year-olds in Scotland. 15,000 kids in Scotland have seen our STARS programme, which is, never too young to start thinking about brain health. So this is very much a life course approach. And in such, we're not just about a clinical service. We recognise that if you're going to really move the dial in terms of the incidence of dementia in later life, you need to start at a public health level in younger people across the life course, right up what we call our brain health pyramid, to targeted populations. So, for instance, people with a family history, the sports players I'll talk about. We've also got a significant programme of work for women who've been subject to domestic abuse and intimate partner violence. They're a very high-risk population. And then we've got the brain health hubs, which are community-based centres, and then ultimately at the very top of the pyramid, the brain health services themselves. The one thing I'd probably want to emphasise in this slide is these are not memory clinics that do MCI better. These are completely different. If we're going to design a sports car, we don't start off by redesigning a tractor. It's been a fresh start with risk profiling, early disease detection, personalised prevention plans. So these aren't just memory clinics with a better MCI pathway. And we articulated this in a paper we thought it was important to have this peer reviewed, if you like. So this was published in JPAD towards the end of, I think, last year, and has been reasonably well cited and read as an exemplar of one approach to doing brain health services in Scotland. And this isn't my slide, but it's a slide that I've borrowed from an organisation called Digital Health and Care Innovation Centre, which is another sort of branch of Scottish Government. And I think the one thing that I really feel as we go deeper into the 21st century is we need to move away from this addiction from hospitals and actually recognise, particularly in the UK, we can say we really don't have a national health service, we've got a national illness service, and we should focus much more on health and prevention, and that's what this slide illustrates, I think, beautifully, where the kind of mountain becomes a nice happy smile. There it is. So I'm aware of the time, and I think it really is important we get some chance to chat afterwards. So I just want to pick up 3 things from this really busy slide. Number 1, far left, direct access. You can walk off the street into a brain health hub. There's one just opening in Aberdeen on December the 4th. You heard it here first. I probably wasn't meant to announce that. Walk off the street. I've got concerns about my brain health. I've got early symptoms. I've got concerns. I've got a strong family history. You walk in and you see what we're calling a brain health navigator, who walks you through, second big point, triage. Not everybody gets a lumbar puncture at the front end. In fact, we'll probably do less lumbar punctures and less brain scanning because we've got better triage points. And the third thing is from this, and I know it's a very busy slide, is research participation. So there's multiple points there where people can get involved in clinical research. Clinical research in the future becomes clinical practice. So this system will work perfectly well for both. I was approached by Scottish Rugby about 3 years ago because they have a high-risk population, people who've played contact sport, soccer players, football. See, I do these things in America too much now. Football players, rugby players, hockey players. They were very excited by what we were doing, so we set up a brain health clinic at my happy place on a Wednesday afternoon. This is my clinic. This is the view from my clinic, I should say, at BT Murrayfield, Scottish Gas Murrayfield. And this is where I see the patients. It's really actually important. It's respect. How many of our memory clinics and brain health clinics look like an afterthought? There's no hospitality. They're in sort of dreadful parts of the hospital and what have you. Scottish Rugby said, no, these people are important. So we've got a director's box at Murrayfield where we run the clinic. That's what Scottish Rugby did to respect their ex-former players. So the patient that came to see me, no photos of the actual case study, because this is somebody who could be identifiable. He's given consent for this, but no photos or tweeting of this. He came along to see us to saying his motivation was he wanted a baseline assessment, and if something was wrong, he wanted to know about it. He wanted to know about it earlier. He filled in a lot of details about his lifestyle, medical comorbidities, way ahead of the clinic, posted it back. I scored it up. I looked at it with him, and we didn't have to spend an hour or two going through all of those different risk factors. Physical examination done to look at medical comorbidities and any expression of disease through cognitive physical examination and MRI imaging. This is my penultimate slide. So what we have is, rather than in the future, yes, we'll have a score, 73.4% chance of X, Y, or Z. But a traffic light system is probably good enough in the first instance. So my gestalt is your diet's amber, your sleep's green, your alcohol's green, et cetera, et cetera. And what you then pick out of this in the personalised prevention plans is the area you want to focus on. So for him, he had amber for diet, exercise, head injury, hearing loss, anxiety. He was hypertensive. His health literacy was dreadful, by the way. And these are ex-international rugby players. You've got no idea how poor the health literacy is with these players, let alone the general population. So cognitive testing was absolutely normal. I do not want to wait for people to come into clinic when their ASR goes down to 80. I'm so delighted his ASR was 92. By the way, 3 people have scored 100 out of 100, and they're all women. Huh? Who knew? And then everything else fine. The MRI scan was the important bit. He had microhemorrhages, okay? And this was related to his hypertension. He had end organ damage already from being an unknown hypertensive. So what we did was we shared all that data with them. I don't write to the GP, I write to the player, and they share with their GP if they want to. Talked about diet and exercise, talked about managing potentially weight and BP through that. Asked the GP, or asked him to ask the GP to monitor and treat the blood pressure. And he said, with a lot of detailed discussions about his anxiety. So final slide. You really need, if you're going to take on a brain health approach, you can't just pick up public health or clinical or target population. It's the whole thing. You need the whole ecosystem in one go. Unfortunately, I live in a really small country, so you can do it. You can wrap your arms around all these things. The clinical services are now nested within a public health directorate, not mental health. This is not a psychiatric condition. I'm a psychiatrist. This is not a mental illness. Okay? These are brain diseases, and the interventions at the population level need to be driven by experts in public health medicine. And also, the patients love it. I've seen about 30 people in clinic, third are women, 2/3 men. They all get it. They all realize there's something really important about early detection. They feel empowered. It's action-orientated, provides a fantastic baseline. We're going to follow them up again in 2 years' time. And like I said, they have all found it helpful. 30 seconds for Q&A. Sorry. I tried.
Don't forget your glasses. Okay. So I am going to take a couple of questions. I had some planned for, Marguerite, do you want to join us back up at the front for questions? But if there's a question out here burning, we want to make sure that we get that. Anybody have a question out here that they want to make sure that they ask? If not, I've got one, and then we can give last remarks to Marguerite. Okay, so I'm going to ask one question, and Craig, we really rushed you at the end, so I'm going to throw this one to you before hopefully you all can stay to get the closing comments from Marguerite. So, Craig, you talked a lot about, and I think rightly so, that this is not mental illness, this is a brain disease, that there's a public health aspect and a clinical medicine aspect. How do you balance this conversation with your patients about things that they can do that are lifestyle modifications, recognizing that this is a progressive neuropathological disease?
Is this working? So I think one thing Marguerite said, and I picked it up, is when you were given the diagnosis, you said, "What did I do wrong?" And I think the problem is if we over-focus on lifestyle interventions and comorbidity, there's a risk that people will feel they may have done something wrong, that had they not done it, they would not get dementia. And I think that is really unfortunate and probably also untrue. There are probably things we can do in our lifestyle that may reduce our risk, but they'll never reduce that risk to zero. So I think we've got to be careful that we don't almost like patient blame, that they've done something in their previous life or their life that they could have done differently, and they shouldn't feel guilty about being a smoker or having alcohol or what have you. Because at the end of the day, this is a brain disease. It's not a lifestyle illness. Now, what we have to do, as you can see from my slide, is make sure that we do both. We look at lifestyle factors like we do in any branch of medicine. We manage those as effectively as possible. But there will be people who get breakthrough disease, and that's where pharmacological intervention is going to be helpful. So it's not either or, it has to be both.
Yeah, I think it's so critical. Having worked in multiple different disease states, there are things that we can do, right, to make our bodies and our brains more resilient for this disease. But I think the last thing we want by advocating for lifestyle modification is patient shaming for the patient who does actually do all the right things, or maybe like me, still would like a glass of wine occasionally as I socially engage, but that we don't shame patients when this disease comes from them. So I thought it would be very appropriate, and I think the microphone is still over there, if we actually gave the final words for this session to Marguerite. Marguerite, you have a captive audience, both here in the room, which is still packed, thank you, as well as online. Your call to action, what would you like to ask of this group for yourself and for the Marguerites coming behind?
The people who are diagnosed, I ask of them to keep going, not to stop. Keep joining your memory cafes, keep talking to people, and keep pushing as much as you possibly can. And then for their carers, keep going. And also, never to not ask for help. It's really important for carers to ask for help. You know, maybe the person can't, but for the carers, because they're doing such a big thing also for the country, you know, saving them billions, and also for their person. So they need to really be careful and mind themselves. So keep going and keep asking for help. And for the people like these guys that are doing so much great work, I also say, keep going. You know, just don't give up. It's really easy to say, oh, I can't do this anymore, you know. I always take it on a daily basis that just do as best you can for that day, you know. So my thing is just please, for everybody, for the Marguerites, the Helens, the Chris's, you got to keep going. You got to keep going, you know. Don't give up. Just bang on the doors of the governments, bang on the doors of everybody, and just give them a pain, you know. Let's keep going.
Okay, you guys got that. Thank you to Alzheimer's Europe for having us and to Lily for sponsoring. And I expect you to go bang on some doors. So let's go.